watching. And then if you go to slideshow now, Charlotte, at the top. That's it. Perfect. Yeah. So thank you, everybody, for coming to this webinar this evening. This should be a really good one, actually. Canine mast cell tumours, diagnosis and treatment with Charlotte, who's an integral part of our oncology team here at VET.CT. But just before we go into the talk, I'm going to take up a bit of the bandwidth and just talk about why we're here, what we're trying to do, and how we're trying to promote things, really, and a little bit about our service, which is the Specialist Case Advice Service. So Charlotte, if you could just move the screen on, that'd be great. So VET.CT, you're probably very familiar with VET.CT if you've already registered for this webinar and hopefully seen a few of our other webinars as well. What we are really is we're a global team of over 200 specialists, and essentially what we're here to do is to help you guys in clinical settings, clinical practice, universities, specialist centres, primary vet centres, wherever you are in the veterinary world. We specialise in three broad things, which is, of course, exceptional radiology and advanced imaging diagnostics as well, so CT, MRI, ultrasound as well. And that's what VET.CT's predominantly known for, but actually what we're talking about tonight is the Specialist Advice Service. And I'm Richard Artingstall, by the way, and Director of the Teleconsulting Service. And we have a third arm at VET.CT as well, which is our education services. So we promote education to students, and we bring on the next students in diagnostic imaging and residents, and help specialty centres train the next specialists of the next generation as well as doing webinars and resources through our website on all sorts of different disease profiles, conditions, disciplines, and everything like that. So we're here to talk about the written specialist advice, and we've got a series of webinars that we've done, and really it's to showcase our team. We've got a really big team of specialists here to help you. Essentially what we do is we provide written specialist case advice really quickly to you guys in practice. We've got a team of around about 50 different specialists in 11 different disciplines. The main area is 12 to 24-hour written advice. But we also, in oncology, internal medicine, neurology and orthopedics, have live appointments as well, where you can book live appointments to speak to our team and be sort of talk through cases with them. That's in the period of 12 to 4 p.m. UK time, or 1 till 5 p.m. Central European time. But mainly we provide written advice to treat cases in-house. We also help make that secondary pathway accessible as well, about giving advice about when maybe a case should move on as well. So it helps with that secondary sort of referral specialty centre. You can rely on really fast turnarounds, like we said, 12 to 24 hours, often sooner, depending on the structure of the day. And we see this as part of a conversation. We know that clinical cases aren't just a one-stop transaction where you just get something and move on. We're not just a lab report. We're part of that relationship. And we're a bit like a specialist team sitting on your shoulder, really, where you can tap into us. And so we have unlimited follow-ups, which creates a conversation around a case. It enables us to ask questions back to you, and you guys to ask questions back to us as well. So that's really, really powerful. We provide detailed notes to add to your file. So we have a PDF output, we have an HTML output, which you can copy and paste and put into practice management systems. We find that actually these shareable formats, a lot of people use internal messaging groups, WhatsApp, iMessage, anything like that for practice life. And actually often these documents can be shared for handovers or transitions and stuff like that. So we absolutely integrate ourselves into the working way in your day. We know that your clients are absolutely delighted to stay with the vet that they know and trust, so staying with you guys, whilst having that specialist input as well. And we also know that we give massive reassurance to our clients, which are vets, giving clear and detailed next step to help reduce that. You're on your own or in a team, or you've got a busy day. It's sometimes that uncertainty about what are the next steps, what perhaps is the right thing to do here, or where you completely just need a new set of eyes on it. We're really easy to use. We've got, you can use the desktop through the website, so scan the QR code, you'll get lots of information there. And we have an app in the App Store as well, which is really, really good. You can use that in the day to download stuff. You can dictate into it. You can take photos, videos, multimedia, all sorts. So it's a really accessible way. Either that on your phone, or some practices have tablets as well. And to actually pay for us, you don't need a subscription, but a lot of our clients have subscriptions. The subscriptions are massively beneficial cost-wise, but you can actually get advice case by case. So you can use us once and have that open case for that patient as well. So do have a look at our services, have a look at our disciplines. Like we said, we've got 11 different disciplines, but we're talking about oncology tonight. So yes, so Charlotte, if you can just move the slide, that'd be great. If you do need a demonstration or any other advice or anything like that, then do contact me directly, richard.artingsall@VET.CT.com. Okay, next slide if we can. So just a little bit about the webinar tonight. It is going to be recorded, or it is being recorded, and so everyone should get a link as soon as this finishes, within a couple of hours. There will be questions at the end. There's a Q&A box at the bottom if you want to put your questions in that as they come up, or at the end. And I'll be sort of having a discussion with Charlotte around those questions as well, so asking Charlotte those questions. We don't have a microphone system on this Zoom link, so there's not the ability to ask questions or to do anything like that. Okay. So next slide, if we can. So delighted to have Charlotte talk tonight. So Charlotte is one of our oncology specialists here at VET.CT, part of the team. We're a very busy oncology service. There's lots of cases that come through, lots of questions, lots of really unique situations, and the team does a fantastic job. I'm going to hand over to Charlotte talking on mast cell tumours. I'm really interested in this subject because I was previous to this a surgeon, so I've seen lots of mast cell tumours, and I know that in general practice when I was in there as well, we saw lots. So it's going to be really interesting just to see how this fast-moving subject sort of changes and what the latest advice and tips from Charlotte will be. So thank you.
Perfect, great. Yeah, thank you all for joining us. If you're in the UK, I know it's been a beautiful day. You've probably been at work or trying to enjoy it. So I do appreciate anybody who's listening real time, kind of coming and spending evening with us. And I guess the reason we chose mast cell tumours, as Richard alluded to some degree, you know, it's certainly something I expect you'll be seeing in first opinion practice as a clinician in a referral hospital, as well as working for VET.CT. Definitely it's cases that I see on a weekly basis, our surgery team see every week. And also through the teleconsulting service, we see a lot of advice requests regarding mast cell tumours. And so hopefully this gives you a bit of an idea of maybe how I approach cases. When do we use what diagnostics? When do we use what type of treatment? And hopefully either kind of confirm that, yes, the approach that you're planning to do for the case, you know, seems a reasonable approach, or maybe there's some additional things that can help you with your cases as well. So hopefully following this webinar, my hopes are that we'll go through diagnostic approach, treatment recommendations for mast cell tumours in dogs, understand and know indications where we might consider additional therapy beyond surgery, which I know you know is generally the treatment of choice, and what other options we have when maybe there's a non-resectable tumour. And also linking to that, what prognostic factors link to mast cell tumours in dogs, and how does that influence how I work up a case and potentially how I consider treatment. So we'll talk about prognostic factors first, and the reason that I bring that into at the beginning is there are a lot of things that you can do when the patient walks through the door, once you've got a hopefully straightforward diagnosis of a mast cell tumour, that can influence what you do next and also what discussions you might have with the owners. So that's why I'm trying to highlight that to begin with. Then we'll talk a little bit about staging. What staging do we do? When do we do it? Do we do it in all cases? How do we treat the local tumour? So again, we all know surgery is typically what we would look at doing, but maybe there are situations where surgery is not an option, or are there other therapies that we can consider? When do we look at systemic therapy? Systemic therapy typically for muscle tumors is going to be some form of chemotherapy, and then we'll try and piece everything together with a diagnostic approach. So we know mast cell tumors are pretty common tumors, and we're all going to see them, and I find them quite frustrating. And the reason for that is that they can be quite variable in how they behave. And maybe that's for me as an oncologist. I get a certain subsection of patients and tumors that come to see me. But I think overall, the difficult factor that we have is that the majority of these tumors we can successfully treat with surgery or with some form of appropriate therapy. But there is this proportion of tumors that have a much more aggressive behavior. And it's difficult to predict which tumors and which patients that is going to be the case. So from my perspective, that's a frustrating situation, because I want to do the best for my patient, and I also want to give the best information to owners. And I guess that difficulty in predicting behavior probably relates to the fact that we maybe don't know enough about these tumors. So that there's some factors that, despite all of these things that we look at for these tumors and how we diagnose and what factors we can influence treatment, there's additional factors that we're maybe not aware of that has a bearing on how they're going to behave. So I can appreciate if you get frustrated with these cases, if you find that there's differing opinions on how to treat them, but hopefully this will give a bit of an overall picture. So starting with our prognostic factors, and the good thing in these situations is there is something that we can look at doing as soon as the dog walks through the door. And yeah, some of it may be kind of common sense, and it, the tumor is looking aggressive, and for mast cell tumor, yeah, we do worry about how it's going to behave. But there might be some additional factors that you're not aware of or not as common that also help us understand things. So we know that certain breeds are definitely predisposed to developing mast cell tumors, but there are breeds that are more predisposed to more aggressive tumors, such as the Shar-Pei, and then less aggressive tumors, so the pugs and the other brachycephalic breeds. So that can help influence how you're feeling about the tumor. Of course, reasonable, rapidly growing tumor, fixed ulcerated, nasty tumor, like the two in the top pictures there, you're certainly going to be thinking, oh, this isn't looking as good as compared to maybe the little small 1 centimeter cutaneous mass that you might find in other patients. If we have a recurrent mast cell tumor, if we have a patient that's systemically unwell that we find is linked to their disease, inherently those are going to be more aggressive tumors. Things that you might not be as aware of: location of the tumor can predict how they're going to behave, and those situations doesn't always relate exactly to the histopathology results. So just having a tumor in a particular area of the body can be associated with better or worse behavior. So to highlight that just a little bit more, the one that gives us maybe a better outcome, a more benign behavior, will be the ones that are associated with the eyelid or the conjunctiva. Not something we see frequently, but overall those tend to have a pretty good outcome if it's possible to manage and to treat them. Whereas other factors, so other locations, it's generally the flip side. They tend to have much more aggressive behavior. So mast cell tumors originating within internally in the viscera generally, unfortunately, have a pretty grave prognosis. Tumors overall that are in the region of the head, associated with the muzzle, and the perioral or oral regions, overall have more aggressive behavior, and it's certainly been found that they have a higher rate of local metastatic disease, but can overall have a reasonably good outcome if we do multimodal therapy. There's a little bit of controversy for the tumors that are located in the inguinal, perineal, scrotal region. Historical papers suggested that they had a much more aggressive behavior. There's some tumors that I think don't sort of fit into that category, but it is a location to be a little bit more worried about. And I would say probably ones that on the pinner are ones that have caught me off guard in patients previously, where the primary tumour itself has looked fairly innocent, but actually they have been ones that have behaved more aggressive, either locally, been recurrent, or developed metastatic disease. So I'm definitely a bit more twitchy now about the mast cell tumours that are diagnosed on the pinner. You're probably aware that we can get subcutaneous mast cell tumours, and these mast cell tumours, I guess for me, it gives me sometimes a bit of a wake-up call. That dogs can have a subcutaneous mass that can feel like a lipoma, for instance, a soft sub-Q mass that ends up being a mast cell tumor. So that just kind of highlights to me that ideally, if the owner is possible for them, that we're aspirating all masses that are new to the patient when they're coming in for investigations or coming in for routine assessment, because it's not uncommon for a patient to refer to me that has had a subcutaneous mass that has maybe been thought to be a lipoma that ends up being a mast cell tumor. And these tumors generally have a pretty good prognosis. In some of the initial papers with the subcutaneous ones, they seem to have a lower overall metastatic rate than some of the cutaneous tumours. There's been more varying reports of that in some of the more recent literature. So some might have a lower metastatic rate, others it might be something that is similar to a cutaneous one, depending, of course, on the grade of cutaneous tumours. Relatively low recurrence rate if adequately treated. And from a perspective of how we analyze these tumours in these patients, the important thing to be aware of is that your histopathology, grade is something that we'll talk about in a second, that is pretty important for mast cell tumours. That grading scheme is based on cutaneous mast cell tumours and has not been evaluated for subcutaneous tumours. So when talking to an owner, sometimes we get into routine, of course, of saying, well, if we remove it, we'll look at the grade and then to see what we do next. The pathologist is not going to give you a specific grade for a subcutaneous mast cell tumour. They may give you an indication, so they may say, if this was cutaneous, it would be classified as a high or a low grade, but you do have to interpret that with caution, in that the grading schemes were not formulated for these tumours. There is some suggestion that overall it does correlate pretty well, but there are other factors that we can look at on your histopathology that might give you some indications about how the tumour is going to behave. So mitotic index, infiltration, and some other factors that we'll talk about in a second from a histology perspective. So I've looked at a little bit, dog comes through the door, some of the factors that we're thinking about just looking at the patient. And there is obviously, as you're aware, a big focus prognostically on histopathology and looking at the tumour after it's been removed and getting an idea of grade of the tumour, which we know is a strong prognostic factor. As you've likely seen in your histopathology results, you will often get two types of grades, so one under the Packniak scheme and one under the Q-form. The Packniak was the initial grading scheme that was done, and it graded the tumours 1, 2, 3, or low, intermediate, high. And the majority of the tumours, and certainly what we tend to find, grades 1 or more frequently grade 2. And most of those had a pretty good outcome. But there was a subsection of the grade 2 patients that their tumours behaved more like a grade 3. And it was very difficult to try and identify those patients. And so they looked at another sort of group of pathologists have then come up with a different system that looks at low versus high. And that has been better at trying to differentiate these cases. So potentially outlining those kind of more aggressive grade 2s into a high grade. And the good thing about low versus high, there definitely does seem to be a better agreement between pathologists as to what grade the tumour is going to sit in. in comparison to the pattern, there was quite variable agreement between pathologists. So this is something that you will definitely see on your histopathology report. You will likely get both of the grading schemes, or should get both of the grading schemes, and that can help you certainly give you a strong idea of how the tumour is going to behave, and maybe help you decide if adjuvant therapy is recommended. We know that there are other factors that we can look at from your histopathology report, some things that will inherently be in the report, as with any tumour, and other things that might be suggested by the pathologist, or things that you can do as additional tests. And they're trying to evaluate cellular proliferation. So inherently, we think, of course, if the cells are proliferating really quickly, inherently it's going to be a more aggressive tumour. And there are factors where we can look at how many cells are in the cell cycle and how quickly they are going through the cell cycle. Unfortunately, there isn't one parameter that is going to look at all of those factors and give this sort of easy, this is a cellular proliferation number or marker, but there are tests that look at individual aspects of that ideally are looked at as a combination rather than as a standalone thing. On all of your histopathology results, so whether it is for a mast cell tumour or lots of other tumours, there will be an indication of mitotic index, and we know that is prognostic for lots of tumours, including mast cell tumours. And that is a factor that's looking at the number of cells in M phase of the cell cycle. And we know that a higher mitotic index for dogs with mast cell tumours is likely to be associated with a worse prognosis, and dogs that have a pretty low value overall will generally do fairly well. Although, again, these unpredictability of these tumours, it's not always the case, but definitely it's a good parameter to be looking at that's already going to be included in your report. And as the grading scheme, there's factors that consider the mitotic index in what grade the mast cell tumour is given. Likely, if you have got your histopathology report from certain labs, they may suggest additional tests, and I think probably one of the most common tests that is suggested as an add-on will be the Ki-67, and that looks at the cells that are in all phases of the cell cycle. There is another factor called AGNOR, which looks at how quickly they're going through the cycle, and you can actually do a combination of both of those factors to give an overall cellular proliferation. So these will be the add-on tests from your standard histopath. Do I do them frequently? No. It wouldn't be wrong to do for every tumour, and probably in an ideal world we would do, but of course, things can become costly if we're adding lots of tests onto what has already been done or what the client has already spent. And therefore, for me, choosing these tests are going to be tests that I do that are helping me decide what to do next. So if I have a tumour that I know is a high-grade tumour, we already have evidence of metastatic disease, there's other negative prognostic factors, then these factors maybe are unlikely to change how I proceed, because I'm worried about the behaviour anyway. So these tests may be more of a consideration in patients where we have a query of how it's going to behave. So everything is looking pretty positive, but there's one negative prognostic factor. And you then may add in these additional tests to try and prove that, yes, it's going to be fairly well behaved, or no, we've got another factor that's a bit of concern. You'll also likely be aware of c-KIT mutation, KIT expression, and this is a factor that's linked to both behaviour of mast cell tumours and also on a treatment perspective. I'm sure you'll be aware of the tyrosine kinase inhibitors, Palladia and Nasivet, which are used for some tumours. What we know is that c-KIT is a gene that encodes for the receptor tyrosine kinase KIT. That binds to stem cell factor in canine mast cell tumours, canine mast cells, and that is important for various different factors in relation to those cells. What we know, if there's a mutation present, then that is for certain mutations likely to be a prognostic factor and is more commonly seen in higher grade tumours. One of the things that we do know is that dogs that have that mutation are more likely to respond to the tyrosine kinase inhibitors. However, the thing to say about that is that they don't have to have the mutation before you can consider treatment with one of those drugs. Yes, they might respond better, but it's not a kind of requirement for considering treatment. It's more just an understanding a little bit of prognosis and may help to direct your therapy in some cases. So those are factors, prognostic factors that one can be fairly straightforward for us to assess with the patients presenting in the clinic with a diagnosis, which generally we're achieving by just defining the aspect of the tumour. Of course, there are some aspects in terms of grading and such which we're only going to be achieving once the tumour has been removed. You potentially might get some information about behaviour based on cytology. So there is some suggestion that factors within the cytology that can be seen by the clinical pathologist can give them some ideas as to whether we think it's a low or a high grade tumour. Again, cautiously interpret that information, because we can only technically get a grade when the tumour has been removed. However, it may help with your understanding of maybe how this tumour is going to behave. Next step that we look at is staging. So ultimately, staging is really just looking at has the tumour metastasized elsewhere. For mast cell tumours, we have to think about what staging we do. Do we do it for all patients or not? Again, it wouldn't be wrong to do full staging for all mast cell tumour cases, but it's probably not necessary. And therefore, understanding the implications of doing the staging, what that means for the owner and the patient, are of course very important. Overall, we know that a lot of dogs with cutaneous mast cell tumours doing, as I said, full staging is not typically required. And for me, I always recommend assessing the local, regional, or the sentinel lymph node. There is a reasonable percentage of patients that will have lymph node metastatic disease, in comparison to distant metastatic disease, which is fairly uncommon for us to see at the time of diagnosis. What lymph node do you assess? So the sentinel lymph node is basically the lymph node that the tumour is going to drain to. So we know if there are cells that have left that tumour, theoretically they should be going to what we call the sentinel lymph node. And that isn't always the anatomical lymph node based on where the tumour is. So in a perfect world, we identify exactly what lymph node we need to be aware of, and we could potentially sample that, or we can remove that as part of our treatment for the tumour. Of course, identifying that lymph node does come with additional steps and potentially additional facilities or equipment in your clinic. So I appreciate that's not always possible. For us in our clinic, I've got the luxury of having a CT. And so generally to look for the sentinel lymph node, we will do a preliminary scan. We will inject contrast around the tumour itself and then do a follow-up scan. And you should be able to see that contrast moving in the lymphatics to identify the sentinel lymph node. It becomes important for some of the tumours, maybe you have a tumour that's on the head region. We know we have a lot of lymph nodes in that area, and it's difficult to know exactly which lymph node the tumour is going to move to if it is going to spread. And if we're also thinking about removing, if we can remove one lymph node rather than 3-4 lymph nodes, then that is ideal for the patient. In some cases, it is, histopathology is always preferred to cytology. So we might decide to remove the lymph node once we've identified which one we want to remove, or anatomically, which ones we think we should remove, just depending on how easy that is as well. Because I appreciate, saying, oh, let's remove this 2 millimeter axillary lymph node is not always practical. In cases where we don't have the option to do sentinel lymph node mapping, then it's using your anatomy and thinking about lymphosomes and where regions of the body will likely drain to have a think about for the location of that tumor, what are the important lymph nodes to assess. And sort of size and appearance of a lymph node on the scan is not always predictive of involvement. Of course, if we have an abnormal looking lymph node, a very large lymph node, then that's going to increase concern. But a teeny tiny, very normal looking lymph node doesn't rule out metastatic disease with mast cell tumors. When do we do additional tests? So this is, I think, kind of area that becomes a bit more grey with mast cell tumors. From my side of things, what I will consider in terms of additional staging will be based on patients with negative prognostic factors, including if I've identified the local, regional, or sentinel lymph node as metastatic. With additional staging tests, typically for me, that means abdominal imaging and FNAs of the liver and the spleen. The reason that we take FNAs is that those organs can appear very normal on imaging, but still have infiltrative disease. So ideally, if we're looking, we're also sampling to rule in or out the presence of disease. Mast cell tumors very infrequently spread to the lungs. It is possible, but it's fairly uncommon. So thoracic imaging is typically used if we're wanting to assess an intrathoracic lymph node. So we think that is an area that we need to assess. And also if we're trying to rule out non-mast cell tumor disease, so ruling out comorbidities if there's a certain factor that may influence owner's decision or recommendations for dogs treatment. Historically, we used to look at the buffy coat preparation and do bone marrow biopsy. Those tests are infrequently, or there's never something that I generally will be doing with a fairly straightforward mast cell tumor case. So it's not something that I would be considering. And predominantly, that additional staging is liver and spleen assessments. You might be in a situation that to assess the local regional lymph node, the patient is undergoing the sedation or some other form of imaging. So yeah, it's not unreasonable that you then say, well, we're just going to assess the liver and spleen all at the same time. But I just want you to be aware of that that's not necessarily for all cases, and just having a think about why we consider doing it, with overall being thankfully a fairly low yield test because the risk of metastatic disease at diagnosis is fairly low. So how do we piece that together then with our diagnosis of a mast cell tumor, and how do we approach it for that individual patient? So for me, this is of course something that is something that I will consider doing. You might see variation with different oncologists or different clinicians. But overall, in my head, kind of what I want to think of, we know we've been diagnosed with a mast cell tumor. We know that overalls will come to surgeries, often the treatment of choice if possible. So when do I do more staging? When do I consider interventions from a surgical perspective? So I look at the patient and I say, can I remove the tumor with wide margins? If that's a yes, and the dog doesn't have any other negative prognostic factors, then we want to assess the local lymph node or the sentinel lymph node, excise the tumor with margins, submit that for analysis. If we have complete excision, low grade, no other negative prognostic factors, then kind of routine follow-up. So monitoring surgical site, monitoring for new masses. If I have a patient where we think, this is a really tricky location, it's going to involve reconstruction, or, yes, it's amenable to wide excision, but we've got these other negative prognostic factors, those are cases that I'm then going to say, well, let's expand these diagnostics. I'd say it's pretty uncommon for me to do a biopsy to determine grade before we initiate some form of treatment, but certainly the additional staging is what I would consider before then making treatment decisions based on those results. And similar, if you have gone down your other route, excised it, and actually it's a high-grade tumor, we've got incomplete margins, then I may go back and expand my staging from there to see if that then changes my next treatment option. Local control. So we know that, yes, surgery is the treatment of choice if we can do it. There are other options that can be considered depending on the tumor, depending on the dog, depending on owner's preference. If we're going down the route of surgery, it used to be that we were trying to get a wide excision, 2 to 3 centimeters with one fascial plane. Often we will use proportional margins now, so the margins are equal to the diameter of the tumor. And most of the time that is adequate for what we're looking to achieve. That is what we're doing surgically. The other thing that we have to think about following surgery is then what you're looking at in your histopathology report with the histologic margins. So your report should give you, and with any tumor that's been removed, a numerical value for what margins you have. And that's particularly important for any tumor, certainly malignant tumors, and definitely for mast cell tumors. You know, if the patient has a margin of 1 millimeter in comparison to 10 millimeters, I'm going to interpret that differently and consider my risk for recurrence as different depending on other factors such as grade of tumor, location, etc. With the margins, it's important for us to be aware that a high-grade tumor, even if we've got adequate margins, there's still a chance for recurrence. And on the flip side, low-grade tumors, if we've only got a narrow excision, there's a possibility that that surgical intervention may be adequate. So you're considering interpretation of those margins with other factors in relation to the tumor. And, you know, that's important for your other tumors as well, but particularly for mast cell tumors. What else can we do locally? So radiation therapy is certainly used reasonably frequently for mast cell tumors, and I would say the most common reason for its use will be post-surgery. So where we have an incompletely excised tumor and we use radiation to target the remaining cells in the field. You could also use it prior to surgery to try and shrink the tumor down, or in some cases as a palliative approach. Mast cell tumors are very sensitive to radiation therapy, so it can be a successful treatment. From a palliative perspective, one thing that we have to be a little bit aware of is, of course, if we do have a very positive response, is there any chance that we get degranulation of the tumor, and how do we support the patient while they're going through treatment if they have a rapid response? Still, ideally, this would be something that's treated with surgery primarily, or surgery as an initial approach followed by RT afterwards. And of course, when we're using RT, we can definitely include other regions within the radiation field, in particular the local lymph nodes. You have probably all heard of Stelfonta. This is a product that in the UK is first produced by VET.CT. It is what we call an intratumoral treatment. So the medication is injected into the tumor. And the drug is a medication that's been isolated from a plant in the rainforest in Australia. It is currently licensed for mast cell tumors in dogs. However, they are evaluating it for other types of tumors, and it has also been used in humans for tumors such as melanomas. The way that the drug works is that following injection, there is a significant oncolytic and marked inflammatory response that occurs pretty rapidly that will lead to destruction of the tumor. You get development of an open wound where the tumor was, and then generally over sort of a 4 to 6 week period, the site of the wound heals. So it kind of looks, oh, you know, this is an ideal treatment. You know, we don't have to do surgery. We get the little wound and then it heals. there are factors that we need to consider, some pros and cons of this treatment. For me, it is, we've got another tool in the toolbox of options for treatment, but at this point is not something that is a superior treatment to me from surgery. There are certain indications for its use, and it's not a drug that I've currently used off-label, so I have stuck to these guidelines. I suspect that there may be changes or other tumours that we end up it being possible to use it in, but currently I'm making sure that I stick to their guidelines, and I've used it in a few cases. So from an indication perspective, the label suggests that it can be used for mast cell tumours are non-resectable. Now, you can argue that a tumour isn't resectable by being in a location that's not amenable to wide excision. So in the tumour in the pictures there, we wouldn't have been able to do wide excision there to have a primary closure. So that would kind of help to satisfy this requirement. It can be used for any grade of tumour, but they are non-metastatic tumours. I guess the anticipation is going to be more successful on low-grade tumours. A high-grade tumour, we could still certainly get recurrence following treatment. Cutaneous tumours anywhere on the body, but it's restricted to subcutaneous tumours more on the extremities. And the reason for that is on a distal extremity, when a wound is created or that the kind of tumour, as it's being destroyed, it needs an outlet. It needs to come to the surface. And we've got fairly limited tissue and other structures on the distal extremities. In comparison, if you maybe had a subcutaneous tumour over the thorax or over the abdomen, where there is a chance that destruction of the tumour gets stuck deep to the skin and you end up with an abscess that is subcutaneous. So that's the reason for more the extremities for the subcu tumours. And there is a stipulation on maximum size of the tumour and also the amount that can be given per the size of the dog. Some of the downsides to treatment. So first, unless you took a biopsy beforehand and then waited for the surgical site to heal, we don't ever get an indication of grade of the tumour. And that is important when we're thinking about maybe adjuvant therapy or prognosis for the patient and being able to relay that to the owner. So we don't generally, we're not going to get that information if we just treat it without any understanding. The therapy itself, certainly in the initial few days after treatment, is pretty painful. So it's uncomfortable. It makes sense. There's a mass inflammatory reaction that is happening, and that is uncomfortable. So I do find that patients are actually more painful than what they would typically be after surgery, and sometimes can have a longer time to healing than what you might find after surgery. So it's not, quite as simple as, it's going to be an easy treatment and the dog's going to recover really quickly. So just some factors to be aware of. There is also electric chemotherapy. So this is available a few centres in the UK. It is used for a variety of different tumours, but it has been successfully used for mast cell tumours. And electric chemotherapy generally involves more frequently an intravenous chemotherapeutic that is given, followed by an application of an electrical pulse over where the tumour is. And that leads to increased permeability of the cell membrane, entry of the chemotherapeutic agent, and therefore an enhanced cytotoxic effect. There are also some indirect effects that can affect the tumor vasculature. So you can get vasoconstriction and destruction of the vasculature, and also a local immune response that leads to cell destruction. So all of those factors can make it an option for mast cell tumours, both as a sole treatment, so maybe in a small tumour that's in an area that's difficult to resect, or if we have patients that have multiple tumours, or it can be used where we know that we're not going to be able to get the wide margins, so we might use it intraoperatively or potentially post-operatively once you get histopathology and we find that we haven't got a complete excision, so similar to how we might use radiation therapy. So systemic therapy overall, we're meaning the use of chemotherapy. And there are certain indications that we might have for the use of chemotherapy in dogs with mast cell tumors. And those are typically patients that were worried about aggressive tumors. So we've got a high grade tumor, we have a high mitotic index, we have a location that is a poor prognostic factor, or we know for sure we have metastatic disease. So chemotherapy is not typically used for these low intermediate grade tumors that potentially were providing a cure with surgery alone. And there are various chemotherapy drugs that have been used for mast cell tumors, and I guess we haven't got the time to go through each of those in detail. You will see variation depending on the oncologist that's using them, what their preference will be, maybe some factors about the tumor itself. From a TKI perspective, maybe it is the fact that there have been the tumor has been analyzed for c-KIT mutation, and therefore that drug is used preferentially. Probably some of the important things to know about chemotherapy for mast cell tumors. So it's a conventional chemotherapy such as vinblastine is going to target rapidly dividing cells, and the higher grade tumors they have that behavior, and we're worried about the more aggressive behavior. So if we have a grade 1, grade 2 tumor in some instances, if it's not been removed and we were using chemotherapy, you may not have a significant response to that, simply because it is lower grade. It's got a kind of slower and lower rate of proliferation. And so therefore it's just something to be aware of, kind of a efficacy of these treatments. The other thing to understand is that we know we have patients that have had one mast cell tumor. They are more predisposed to developing another tumor at some point in their life. And unfortunately, we don't have any indication that giving chemotherapy post-operatively will prevent them from developing another tumor. So it's not a great use of chemotherapy in those cases. Those cases can be frustrating. But yeah, blanket giving some form of chemotherapy may not change what happens next. We can use chemotherapy in some cases similar to radiation, where we try and reduce a tumor down in size to make it more amenable to surgery. The key thing in those cases is that we still should be trying to take the same margins of what the size of the tumor initially, but it may make the tumor just a bit more manageable from a surgical aspect if we're able to reduce it in size. So just as a kind of bit of a summary as we wrap up from things of our overall diagnostic approach for mast cell tumors. So finding aspirates generally are going to give us definitive diagnosis in most of the cases. For me personally, I always want to assess the local regional, the sentinel lymph node, and my indications for doing further staging is going to be based on the patient, based on other factors from a prognostic perspective. Ideally, surgery is the treatment of choice. We will then going to look at the histopathology results following that surgical intervention, and then decide from there if any systemic therapy or adjuvant local therapy is indicated. So to summarize, for you, certainly for me as well, these tumors are common. You're going to see them. Thankfully, the one positive thing is that overall they're easy to diagnose. It kind of what happens next is a little bit more tricky. For me, my diagnostic approach is determined by a number of factors, and it's not a kind of standard approach with every tumor. If we can do surgery, fantastic, but there are other therapies that can be considered. And so that's why certainly thinking about staging and thinking about alternatives can be helpful in cases that are, not quite as straightforward, and there may be an alternative that can be considered. And we also think about systemic chemotherapy treatment in certain cases based on tumor, based on our anticipation behavior, and also our staging results. So, sorry, it was a little bit of a whistle-stop tour of mast cell tumors. It's a huge topic to try and cover in a short period of time, but I guess my hopes are it just kind of helps with that diagnostic approach and overall thoughts on treatment to help you with the cases that you're going to see.
Fantastic. Thank you, Charlotte. Really good, really good. I particularly like your advice about, using the prognostic factors and then reacting afterwards once you've got the histological diagnosis to sort of go deeper if you need to. You're fairly confident in that approach, are you, that you can take that approach? Because I know in primary practice there was a drive to do everything up front, which you can use a lot of money and then you can get, low grade tumors back, and then you've either spent the client's money in the wrong way, or when you then come to actually try and treat whatever you need to treat, you've run out of funds at that stage. So I think that's
Yeah,
yeah.
yeah, I think that's the hard thing as well. Yes, in an ideal world, we're kind of doing everything, you know exactly the situation before you jump into treatment. But I think more and more, we're thinking about the patient. So what's indicated for that patient, and are we doing unnecessary tests? In the current situation as well, owners' finances are extremely precious, and from my perspective, we want to use those finances to the best of our ability to get the best outcome for the patient. And as you say, it's kind of a very difficult situation if you use all of the pot of money that the owners have for their pet on some tests, and then we don't actually have any money to try and treat the tumor. So it's a balancing act, which isn't easy. But I think these are scenarios with these tumors that we've got some factors that we can look at that I guess help us prioritize what we want to do.
Yeah, absolutely. And again, just because we're advocating for this is exactly where sort of team collaboration and getting advice early really, really helps, because actually guiding that advice can create a lot of savings down the line and a lot better sort of targeted approach as well. So brilliant. Okay, so if anybody's got any questions, then put them in the Q&A box. There are a few in there. So I'll just run through these, but please
Yeah.
feel free to do that. So Vera asks, good evening, thank you. Very interesting presentation. Like some advice on how to improve the quality of CT I can never say it. Lymphography.
Lymphangiography. Yeah.
Lymphangiography, to search for sentinel lymph nodes. So I think they performed the study with peritotumor inoculation, so injection into the tumor or just around,
Mhm.
of iopidamol, which is I presume an iodine based, following what
Mhm.
is reported in the big bibliography. My experience, however, many times the exam is not conclusive because I cannot visualize the lymph node. Have you got any tips? What might she be doing wrong?
Good question. I don't think that you're doing anything wrong. That it's very similar approach to what we do. There are certainly some situations that the lymph node isn't easy to identify. That it kind of doesn't end up working, but I would say in the majority of cases it does. Sometimes we end up doing a few more scans so we can kind of see the contrast moving. But at the kind of time intervals that our team do, maybe it's not got to the point where we we can identify the lymph nodes. So we end up doing a few more scans afterwards to then hopefully it's identified. But it doesn't sound like you're doing anything wrong. But yeah, I guess if there's anything that's follow up that we can also ask our imaging team here. I think we maybe have a bit of a standardized protocol that they might have as well. So that may be something that could help.
Yeah. Okay, Pernille asks, have you got an experience in the UK that increasing proportion of subcutaneous mast cells behave biologically more aggressively than described in the literature? So this is sub-Q mast cells. Are they potentially more aggressive, in your opinion, despite
Yeah,
low mitotic counts?
I think that some of certainly the initial paper that came out quite a while ago for subcutaneous mast cell did seem to kind of predict them to be all kind of pretty well-behaved tumours that we surgically excised, and they were pretty rare for them to metastasize, pretty rare for them to recur. I would say that there's definitely more information that there are subcutaneous ones that have more aggressive behavior, which has been identified in some of the couple more recent studies that have looked at these tumours. I guess the question a little bit is, we also probably evaluate or remove more lymph nodes than we historically used to for mast cell tumours. So I think that we also see cutaneous mast cell tumours that we've got a much higher proportion of lymph node mets than historically, and I don't think that that's changing behaviour. I think it's just we're removing them, and I've got a better way to analyse them. I do see probably a seemingly higher number of subcutaneous mast cell tumours than maybe I'd seen before, but I don't know also whether that is that we're more aware of them, or cases that referred to me. We're doing much more fine needle aspirates of masses, and owners are interested in investigating it, and so we're diagnosing more. But yeah, I think from my perspective, I'm not I'm not seeing necessarily the cases that were in the initial reports of pretty benign tumours. I definitely think that there are some that are nastier, not necessarily ones that we can't treat, but definitely ones with more aggressive behaviour.
That's great, thank you. This is a great question as well from Vera again. Do you always recommend performing liver and spleen fine needle aspirates, or only in the presence of nodules, which I presume is sort of lymph nodes up? I've experienced this as well. I think different opinion, isn't there?
Yeah, there is differing opinions, and there's differing literature as well. So it will vary depending on who you talk to. Overall, I guess the one thing to say that the liver and the spleen could look grossly completely normal and still have mast disease present. So my recommendation is, if I'm imaging those areas, even if there are no nodules, even if the liver and spleen look completely quote unquote normal imaging wise, I will take aspirates. That is not, I guess, necessarily the consensus among all oncologists. I think it's probably the favored consensus, simply because we do know that we could miss some. So while you're, if you've got a differing appearance, you're going to have some increased concern. You don't tend to see nodules. It does tend to be a bit more of a diffuse change. So unlike for other tumours where you would see kind of a nodular appearance with metastatic disease, it's more kind of a potentially enlargement and diffuse changes to the parenchyma. But yeah, ideally, I personally would suggest FNAing if you're at the point of looking at them with ultrasound or CT.
That's great. So this is a really good question as well, actually. Following lymphography, do you remove the tumour lymph nodes and all parts that are identified with contrast, so including lymphatics?
So there's, I guess, two options when you've identified the sentinel lymph node. If we're going through that procedure, I will typically do a fine needle aspirate at the same time, just to see if there's any overt evidence of metastatic disease cytologically. We know that histopathology is better than cytology at assessing. So I probably would say that myself and the surgical team that I work with, we do tend to lean more towards now surgically excising what we've identified as the sentinel lymph node, if that is possible. But we don't remove any of the lymphatics. It's literally kind of the mass and the lymph node. What we do, I guess how we consider things from there is we will look at the histopathology. If there's overt metastatic disease, then I will consider chemotherapy. You're probably aware there's a grading scheme that looks at the population of mast cells in a lymph node, and it gives kind of a HN 1, 2, and 3, looking at kind of pre-metastatic, early metastatic, and overt metastatic disease. And there's also controversy about what we do with those results and when we consider chemotherapy, and there's varying different opinions there. But overall, I think most from a surgical perspective, we would be removing the lymph node and the mass. There wouldn't be any attempt to remove the kind of the lymphatics. But if we have concern that is a significant proportion of cells that have metastasized to that lymph node, that's going to be an indication for adjuvant systemic treatment.
Yeah. And I've just got one question right at the end. In these sort of cost-strapped times, I suppose, when a owner says, no, I'm not going to go for surgical treatment, or I'm not going to, they sort of not necessarily pay, but they just decline. What palliative or supportive treatments can you give for mast cells? I know it might depend on the type of mast cell.
Yeah, so it can vary certainly. If you've got what you expect is going to be an aggressive tumor. So you have a patient that has a large ulcerated tumor, it's grown really quickly. It's screaming at you that's not going to be a nice mast cell tumor. From a palliative perspective, I guess one of the things to consider is some of your supportive medications. So we know that we can get of course, release of histamine, it can increase your heparin, and therefore H1, H2 blockers are recommended from a palliative perspective in terms of secondary impact of release or degranulation of these cells, which is much more likely to happen if we've got an aggressive tumor. We also know that steroids can be useful palliatively. So there's a couple of, I guess, neoplastic conditions where we actually will see a cytotoxic impact of steroids. So lymphoma and mast cell tumors are the kind of key ones that we think about. So we will often see a response to steroids alone in a more aggressive tumor. There will be an anti-inflammatory component to that, but also potentially a component that is sort of reducing that cellular population of neoplastic cells. Admittedly, the response and longevity of response of those drugs is going to be short-lived, but it is something that can be helpful. In those cases, you might also consider, if the owner was against surgical interventions, but would they consider some form of chemotherapy alone? If we have an aggressive tumor, it might respond for a period of time on chemotherapy. If they were sort of weighing up, well, we think this is going to be an aggressive tumor, we don't have a lot of money, maybe they're not going to do surgery, so the staging might not impact their decision, but they want to try something. So maybe we could initiate some form of chemotherapy along with supportive medications. If we have what seems to be a tumor that we think we could have appropriately treated, so a pretty small tumor in a location that it's not got a negative prognostic factor, no other prognostic factors, that you might say, well, actually, we don't treat it at all. We just, kind of keep an eye on it, as it were. I've definitely had some patients that have been referred to me where tumors have been present for, at least a year, some cases a number of years, and maybe it's recently changed or it's been pretty unchanged over that period of time, and for whatever reason, at some point it was sampled and diagnosed. So, these low-grade tumors can sit there, and if you had a 15-year-old dog that you diagnosed and had lots of comorbidities, and the owner understandably is weighing up what's the right approach for the ongoing care of that patient, then not doing anything for that further for that mast cell tumor might be the right decision for that dog and for that owner.
Yeah, well, that's fantastic advice. Thank you. Okay, great. It's 8 o'clock here in the UK, so thank you, Charlotte, for all your hard work and your talk as well. Really, really good. Very some really good thinking points there, and I particularly like that sort of flowchart pathway as well, because I think that will help people. So thank you very much. That's the end of the talk. I think there's one more slide, perhaps, for me. Yeah. There we go. Right, fine. So we've got more webinars coming up, and if you go to the website, we've probably got about 14 or so of our team now, ranging across all the disciplines: cardiology, internal medicine, orthopedics, everything really, doing webinars. So they're a fantastic resource. And again, if you would like to understand how you can use our specialist case advice, then please do get in contact or just use us for a case. Like we said, we can have a one-off case and just use us. So, but thank you, Charlotte, for everything tonight, and thank you everybody else for coming.
Sorry.
Thank you.